Good afternoon and welcome to the Public Safety Committee. I am Mark Conway, Chair of the committee and representative of the 4th Council District. I'm joined here today by Councilwoman Felicia Porter of the 10th District and Councilman Gray of the 8th District. We don't have a representative of the Mayor's office or the Council President's office here today. They will join us soon. Today's hearing is on LO 25-0006, Baltimore City Fire Department and Emergency Medical Services Operations and Oversight. This is our quarterly meeting that we typically have with the fire department and EMS. We did not have our meeting at the end of the year. It got canceled for some reason. Oh, I think it was technical difficulties. That's what it was. So eager to hear from you, Chief, and eager to jump into what's been going on in the fire department. So,
thank you, Chairman Conway. Good afternoon. Good afternoon, members of the committee. My name is James Wallace, Chief of the Baltimore City Fire Department. With me today, as I always do, I have members of my command staff. Chief Matz and I will be the lead presenters for today. We're going to try to do that in the interest of time, give you more time for questions, but we're happy to be here and thank you for the opportunity. So I'm going to start off, actually, Chairman, I'm just going to recap a couple of things that we had at the last hearing before the technical issues arose. So from on our apparatus status, so FY25 to present, we've taken delivery of 6 engines, 2 ladder trucks, and remarkably 34 medic units. Those medic units were on back order for a while, and I think that kind of exemplifies some of the issues we have with regard to lead time on apparatus, some of the challenges that we face with the tariffs, as well as some things with some vendors. But upcoming in FY26 and 27, we anticipate 9 additional engines, 4 more ladder trucks, 2 elevated platform units, 6 medic units, and 1 pod unit. And just very briefly, the pod unit's going to be a kind of a new way of doing business for us. These are going to be sea containers that are actually outfitted with technical rescue gear so that when we have a protracted incident, instead of clogging the street up with apparatus, we can drop a pod in the street and work directly from the street. So we're real excited about that kind of change of the way of doing business. Again, we still face difficulty with maintaining the 20-year replacement cycle, and this is primarily due to these extended build times. As I'm sure most of you are aware, a lot of vendors have kind of gone into what I'll quasi call a co-op. So it makes things very challenging, not only with having vehicles built, but also with the acquisition of parts, should repairs be needed and things like that.
quick question about the pod unit. Is that pictured anywhere or?
Pod unit is not pictured. We're happy. Some of our partner jurisdictions actually do it. They've done it with great success. Essentially, if you can imagine one of the roll-off dumpsters, right? The truck that pulls the dumpster up on. So instead of it being a dumpster, it'll be a complete container. But the theory is to drop that pod and move the vehicles away so we're not as invasive on an incident scene. Gives us more room to work. So in our operations division, again, just real quick, they staff 39 stations. There's 4 shifts right now. Each falls under a shift commander. Each shift has 6 fire battalion chiefs plus an EMS battalion. There are 32 engine companies, 17 ladder trucks citywide, 3 we'll call medium duty rescue squads, 1 heavy rescue, and then we have an array under Special Operations Command of technical units, including hazardous materials, our fire boats, our Airflex, and our dive team. So inspections, really community engagement is something that we've really picked up on over the past year and a half. This slide shows FY24 data, which reveals well over 57,000 total inspections, home inspections, but within that, I think it's important to note that there were over 40,000 smoke alarms that were inspected, and equally as important, almost 7,500 smoke alarms were installed. These numbers were in FY24. When we move into FY25, you can see a significant increase. We're just under 60,000 home inspections, but we've gone up to well over 45,000 individual smoke alarms inspected and just over 8,000 alarms installed. What I would add to this data is we've also changed the way our engagement is not limited to just knocking on doors and inspecting smoke alarms. We take the time to explain escape plans from the homes. There are certain characteristics that we look for when we're at a home, hoarding being one of them, to try to work through that. So we're not just this isn't a smoke alarm mission. This is a mission that encompasses all aspects of fire safety inside the home. But we're also very proud of the fact that even though we have expanded what it is we do when we're in the home, we're still able to increase these numbers year over year. So these are really, really good numbers. And then for the first quarter of fiscal year 26, we're up over 20,000 total inspections already. And with over 12,000 alarms inspected and over 2,000 installed. So our trajectory here continues to go up in the arena of fire safety and fire prevention. Our well-known initiatives with Codex and Vacants, these numbers represent a year-over-year increase of total active Codex addresses. You see it over a 22% increase, but then in fiscal year FY24 versus or compared to FY25, there's a slight decrease there. We attribute a lot of that to we believe that we've probably passed through the city once and located a lot of these structures. However, also bearing in mind, if we have an occupied structure and it's what we call a burnout, right? It's no longer inhabitable, we will automatically classify that as a Codex. So although that number will never go away, it will continue to be somewhat variable. This doesn't represent, in my mind, a significant change. I think this is data that we kind of expect to see in the years to come. And then again, just FY, or as of September 30th of 24 compared to the same time in 25, there's a 20% increase there. But I think what you see in Q1 of 25 versus Q1 26 is a nominal change there, kind of reflective of what I was just saying. I don't believe we're gonna see these extreme numbers with regard to increases in Codex structures. Our operations division, and quite frankly, our department has progressed in an extraordinarily favorable manner. When it comes to fire suppression operations, when it comes to training, we have really began to focus on critical thinking. We know we're good at firefighting, but we want to continue to build on our ability to think critically in those times of crisis. You've heard me talk before, when they step off that apparatus, irregardless of what the call is, our personnel step into a world that I like to classify as uncertainty. Things happen very quick. Oftentimes things are very unforgiving, and this critical thinking kind of mode that we're in right now, I think that we've seen some really good changes that we'll be able to show you in future slides here. But these bullet points are just examples of some of the things that we've done, whether it be hands-on or technology type improvements. We also have become critical of ourselves. We now do after-action reports on significant incidents, whereas before we would do them behind serious injuries or near misses. Now we do them on a lot of our significant incidents. We post them out. They're not hidden. They're public. They come out on via our email, and a lot of our members take the opportunity to really learn from some of the situations that we've encountered. We're also very proud of the fact that we now use real-time technology by way of the iPads that are in the field. And I would draw your attention to those sub-bullets, because a lot of the information, the ERG, the Emergency Response Guideline, AskRail, anything that has rail behind it, we used to have to make phone calls. And we would call CSX, we would call Norfolk Southern, and we would hope that we could get information. Now, that same information is technology-based. We now put access to that to our incident commanders in the field. So if we have a train derailment, they can get that manifest right away. If we're working on the rail tracks, we know when there's a train coming. We know what's on board that vessel as it moves through. And then we continue to expand our incident command worksheets, which are kind of the checklists, if you will, for our incident commanders on serious incidents. Our structure fire data in FY24 versus FY25, we do see in that year a greater than 50% increase in Codex structure involvement. Really have no explanation as to why codexes were kind of the thing at that point, but we did see increases there. We also saw an increase in structure fires that involved occupied dwellings, but overall there was just under a 3% increase in structure fires year over year from 24 to 25. We see lesser of an impact in Q1 of 25 versus Q1 of 26. The codexes were pretty much even. What I'll say is the numbers were still relatively low, 6 in Q1 of each year. And there was an increase in what we classified as undetermined, meaning at the time we weren't really sure what the occupancy was of the structure during the fire. However, overall, we saw favorable decreases across the board with those remaining categories. And then this just lays out a little bit better view of structure fires in 24 over 25. You see relatively even with regard to what we classify as AF, which is an actual fire in a structure itself. Working fires stayed pretty much even. We did have an increase in second alarm fires. My explanation for that is, by way of training, we involve more people so that we don't burn out a very small group of people over and over again fighting fires. We'll bring more people to the scene to kind of decentralize the work a little bit. Again, a decrease in Q1 numbers, 25 versus 26. There was a decrease in the amount of actual fires that we had. However, there was an increase in working fires. To explain working fires, that's when additional resources are brought to the scene. Given the circumstances, the incident commander feels as though they'll be committed for a longer period of time. A little bit more help's needed. It doesn't rise to a full second alarm, but it does bring additional resources to the scene. And then, as we usually do, we're breaking out just for visual assistance. We break this out geographically. These are suppression responses. These are not just fires. These are overall suppression responses. We do see drops in some of the council districts. However, we see rises in other. Again, this is overall suppression call volume. This is not indicative of actual fires, but these are just response numbers in general for our fire suppression forces that are in the field. Once again, Q1 comparison, FY25 and FY26. These numbers quarter by quarter actually look really well. We're very pleased with the fact that quarter over quarter, the numbers came down. We've got one area in Council District 6 where we had a slight increase there, but generally speaking, we're very happy with the way the call volume has come down across the city. With regard to the fire marshal's office, we laid this out for you kind of all on just this single page. Their FY24 activities, you can see the increases, especially in FY25 in the amount of inspections. Plans reviews did take a bit of a dip there, as did fire investigations. The decrease in fire investigations is not a bad thing. That is that's kind of synonymous with the fact that the fire numbers had come down. Also, it's an indication that our company officers and some of our frontline supervisors were actually able to make cause determinations on fires that did not result in an actual fire investigator coming out. I would also just call your attention to the increase in FY 26 over 25. We had, during this time, hired an additional plans reviewer, and I was told actually walking in here, we've got an interview for another one this week, civilians plans reviewer. So that increase of almost 30% can be attributed there, as well as Chief Hamlin's activities and Chief White to kind of reshuffle the deck over there in the fire marshal's office a little bit, and add some additional measures in there to assist with plans reviews. This slide's one that as a department we're extraordinarily proud of. I think that there's broad brush credit to be given here from training to the safety office to operations and holistically to a lot of our personnel. An almost 50% decrease just in fire ground injuries alone over 1 year shows that the training is working. The leadership is working. The safety officer, we were very fortunate that Mayor Scott funded the second safety officer a couple of years back. So now we have those safety officers that used to come out on working fires. They're now dispatched right from the jump. So they're there. They have to do a 360-degree circle of the structure in addition to the ones that are done before they get there. So by way of that, we've built in a lot of fire ground redundancy when it comes to safety. So this is a significant decrease. I'm really proud of my staff for the way they've pushed this, and for our personnel, the way that they've really adapted to, quite honestly, change in how we fight fire. The next slide just further supports that. This is in regard to burns on fire grounds. Just 2025 from the year prior, 76% decrease there. And we've carried it into this year. Quarter one of this year, we had 0 burns related to any type of firefighting. And in 2026 calendar year so far, we've had 2. They've been very minor. The other thing that I'll add is we've seen we also look at the workman's comp payouts. And we saw in 2024, it was about 8.7 million. In 2025, it was just over 3.9. So again, synonymous with a lot of the changes that my command staff has made and a lot of the initiatives that they continue to push centered around personnel safety. And then this slide just shows progression year over year from 2022 through 2025, showing again about just under a 20% decrease in overall line of duty injuries. To explain line of duty injuries, it's anything that happens on duty, line of duty. It doesn't have to be a fire ground. It could be an EMS call, it could be a vehicle accident, it could be during training. This is holistically, just outside of the fire ground, it's a holistic picture of the fire department. I thought it important to show as we close the gap in staffing. I thought it important to show just the increase in recruit training that's done at the Fire Academy. Just quarterly, FY25, you see a substantial increase there. It almost doubled. We had a class, we graduated 53 members in that one particular large graduation, but we've continuously put classes through, whether they be EMT firefighter, entry level, or lateral entry EMTs or paramedics. We continue to run them through the Fire Academy. That's a substantial increase just in recruit hours, and that's only in the first quarter. So that shows there's a lot of work being done at the Fire Academy. And then this video that we have for you is a project that's going on out there right now. So this is what we call Connex City. The Fire Academy staff is currently working on that. I think all of you have been to the Fire Academy and you've seen the burn building that's out there now. Burn buildings are great. Councilman will get you out there. Burn buildings are great. They're a very controlled environment. But what's being built here is this is being built just out of Connex boxes, sea containers. And the Academy staff is going to arrange this so that, if you look at it, you kind of see row houses there, right? Our burn building does nothing for us when it comes to row house firefighting. We're going to be able to recreate those row house scenarios. There's ventilation scenarios on the back. There's roll-up door scenarios. They'll be able to do bailout training. They'll be able to replicate ground floor fires with people trapped on the top floors. So there'll be a lot of things they're going to do. We're doing this totally, or they're doing this totally internally. The sea containers are all being purchased locally. And when it's done, that's going to be extraordinarily unique. I'm not aware of anything, I could be wrong, but I am not aware of anything like that in this general area. This is going to take us well into the training world. We're going to be well advanced beyond a lot of other jurisdictions. So we're extraordinarily happy to be getting this, but we're also very lucky to have the people that we have out there. This way of forward thinking is really going to put us in a place where we can not only train our personnel, our current personnel, but as we bring in new recruits, we're going to be able to acclimate them to those scenarios right away. And I'm very proud of what they're doing out there. This is going to be a major accomplishment for this department. And along the lines of what I spoke about earlier with regard to critical thinking, so we've had incidents over the year that have driven change, and we've accepted that, and we've made these changes. These bullets represent just some of the critical thinking training that we're putting out there. But what I would do is I would call your attention to bullets 3, 4, 5, and the fact that it says recruit training. This is training that we needed to do in the field, but this is also training that we realized as recruits come in that the time needs to be taken to acclimate them to a Mayday procedure, how to use thermal imagery. I can tell you there was a time when people came through the Fire Academy, they may get an hour, maybe 2 hours of building construction. That's changed. If you look at the city that we're in, the infrastructure, it varies literally from neighborhood to neighborhood. So we realize that we've had to step back, change the way we train. We teach the dynamics of fire. We go in depth with how and why we use thermal imagery, how it can work for us. And then the last bullet is one that I'm very excited about. I'm not aware of us ever having organized marine firefighting for land-based firefighters. We have seen recently, granted the Key Bridge was a major, right? It was a worldwide incident. Everybody saw, but it didn't involve fire. But not long after that, we saw that explosion on that barge offshore in the Patapsco River. We know that the ship that burned in New Jersey that resulted in the loss of life of 2 firefighters, that vessel departed our harbor less than 48 hours prior with that cargo on it. So Chief Shiloh took the initiative to seek out grant money for this kind of training. We're not only able to train a lot of our land-based firefighters here in Baltimore, but we're also sending, and we have been sending incident commanders down to Norfolk for command school for marine firefighting. And we have since then had a fire, and it just so happened we had 3 of them working that had been down there, and it went just as smooth as it could. So we're very fortunate to get this class. This is grant funded, but I think that this also is going to advance our department well beyond where we are now. And just a couple slides for numbers from the Fire Academy. The AFG grant, in and of itself, what we want to really show here is we seek out a lot of grants in order to train our people, and really, the biggest thing that we're trying to do here is achieve advanced training, but we're also being fiscally responsible with it. These numbers represent where overtime is being paid, but by way of the backfill that's allowed within the grant, we're able to backfill or we're able to reimburse our general fund account at that point. And then these are the last two grants that we received. And again, within the critical thinking world, if you will, these are the expenditures for each of the trainings. And FY25, just the total reimbursable overtime there was over $500,000. Finally, a project that we work with other city agencies on, it's been a really good collaboration. This is something that we've been working on for a while, is the Clearboarding Initiative. I know Councilman Porter and I had talked about this almost 2 years ago. We had talked about this, and we've been really working to get this up and running. Clearboarding, we hope, or we have been using it to replace just wood plywood over doors and windows. It's 1/4-inch clearboard. It is about 250 times stronger than plate glass, so it's very, very difficult for someone to defeat it, trying to force entry in there. However, before it went into the streets, we were able to acquire it through partnership with the mayor's office, and our fire academy team actually did studies on this. They looked at different ways to cut it. They looked at ways not to cut it. We burned fires in our burn building with the clearboard applied to see how it melts. Does it melt? How does it fall off? How do we get in? We've looked at this really from a 360-degree standpoint. There are properties now that have this on, that have had this applied. The final piece of that is once that happens, it goes into our CAD system. So as our responders are on the way in there, they do know that they're going to have to defeat clearboard as opposed to plywood on a vacant. That's all for the fire suppression side. I'm going to turn it over to Chief Matz for his EMS report.
We're holding off for questions until after.
Oh, okay. I have some specific questions on fire. Okay.
So as you can tell, first of all, good afternoon, Chairman Conway, ladies and gentlemen of the City Council. For the record, my name is James Matz. I'm the Assistant Chief of EMS. I also oversee 911 and fire communications. We're trying to save you from death by PowerPoint because we've done this before and have, 108 slides, 103 slides. We're down to like 50 some. I promise I'll be quick to fly through mine and then we can go from there. Real quick overview on 911. There's a couple of highlights I just wanted to point out for 911 and FY25. They actually answered over 1.3 million calls, which is huge. It's one of the largest ones around the state of Maryland. Hiring, they actually hired 15 new hires in FY25. They also interviewed 14 candidates for fire dispatcher. And then with regard to fire communications, they just filled 4 of their vacancies. They're actively training people on the floor as we speak now. They also have some extensive outreach. They've been partnering with several, with Parks and Recs, as well as APCO. One thing I did want to point out is one of the last bullets. The APCO Middle Eastern chapter, they won the award for the team for last year. I thought was pretty interesting. Some of the performance metrics that we're working on, one of the performance metrics is to answer a call and dispatch within 64 seconds. In the FY25, we met that goal 85.36% of the time. We have about another 4% to work on to get that a little bit better. I will show you in the next quarter, they've actually have that time, which is better. And then percentage of calls dispatched within 106 seconds. We met the 95% standard for that. For the first quarter of FY26, I wanted to point out, we're up to almost 88% of that. They've had to have the time from the year prior. Part of that is bringing on the news dispatchers to help with that. And then they're at 96.56% for the 106 seconds. Real quick from an EMS operations overview, I did a lot of dashboards. I don't want to kill you with dashboards. I just want to give you some overall numbers. The thing I want to really point out is our incidents are actually slightly down year over year. The thing that's up is our transports. And I wanted to point out that our EMS transports, they haven't been this high since pre-pandemic levels in 2019. Now, does that mean that we're getting good and we're only dispatching to the right type of call? That is going to take some time to look through our data. I'm going to talk a little bit later about some of the innovative things we've put into place. The one thing I would like to point out is our call volume. On a daily basis, for January and December, we actually average about 530 calls a day, and we're transport about 265. This is one of our dashboards that kind of puts a synopsis of FY25. All in all, and this is really important, there's incidents, responses, and transports. There's a unique incident for every call. There can be multiple units on a response. That's why the responses are higher. Like a cardiac arrest can have 3 or 4 units on it. And then, of course, transports we talked about. The bottom number, the 8.72, Dr. Lawner would really appreciate that. That's our response time to serious or high acuity calls. That's where we should be trying to go as fast as we can. Offload times. I know it's been a topic here before. Our offload times, it's great to put median in there, but keep in mind from a manager's perspective, I'm looking at 90 percentile, or 90% of the time, how fast can we get people out of the hospital? We're up from 24 to 25. We're up about 4 minutes. And I just look at the region, I get like a weekly output. Actually, last week we were averaging about 50 minutes, which is pretty much in line with what we're seeing here. In that particular instance, the highest hospital last week was Harbor Hospital, was averaging about 58 minutes for 90th percentile. This is one of the things that I think it's really important to point out. Our response times, we do take a dig for every now and then, but the thing to remember is response time over response time. Our units average on scene time is about 15 minutes year over year. Hospital offload time year over year has been averaging roughly about 50 minutes. That's 50 minutes of our time of our people backed up in those hallways until we can get them out on the street. There's several mitigation strategies we've talked about, and I'm going to go in depth with all those soon. I'm going to go in and explain our telemedicine initiative. Nurse navigation is very new, but I have some real exciting data I'm going to share with you with that. Dispatch reform is still a work in progress. Dispatch reform is where we're trying to send the right kind of apparatus to the right call, and that's a lot of call types that we're working through with the medical directors as well as dispatch. The contracted ambulances, I'm going to talk about that briefly, but we were able to contract as part of our nurse navigation to help take the workload down on our units. And then lastly, alternative destination. It's real exciting yesterday, and I'm just going to go off script real quick. We actually started an initiative yesterday where we are taking our veterans that go to the VA for service. We actually just started that yesterday, and we're actually able to take 2 veterans to the VA Medical Center for treatment. That's where you're taking the right patient to the right resource. Tele 911, this is the latest numbers. Since the initiative began, we've taken 605 people through Tele 911. The thing that's important is the lower right pie graph. 61% of those patients are TIP or treat in place. That's really important. That means we're keeping people at home and not flooding our EDs and so forth. Nurse diversion, AMR. We started working with AMR on 2 fronts. One was to be able to assist our units with commercial surge. They peak out during the day. They run to 10 to 12 units a day. They'll peak up and then they'll gradually go back down. The other part of that is nurse navigation, or they says nurse diversion, but I don't think diversion is a good word. The right word is navigation. What does that mean? That means we're navigating people to the right resource, whether it's an urgent care center, an FQHC. Sometimes they might want to go to the hospital. We're able to use Uber and Lyft to get them there. The thing that's really nice, this is just 3 months of data. From November to December, there's actually been a 36% increase in the use of nurse navigation, where they were up 225 calls. 22% of those calls that we're able to navigate, when we navigate to nurse navigation, they never hit the system. Our units aren't going on the street. They're able to work with a nurse to be able to get those people to the right resource. The other thing, it's nice to have the third party piece in here. They do a 24-hour post call, one to make sure, did something go wrong? Did we do something wrong? And the patient satisfaction, in this instance, was 4.7 out of 5. It's actually 4.8 now. But that means in general, the general public has been satisfied with us. One of the other things that they do that I think it's really interesting, and I'll put it in a slide, they actually ask people, what made you decide to call 911? 77% of the time, the people that call with low acuity or low priority, they think it's an emergency, and it's really not. So I think it's a lot of patient education and things like that that we have to work on. But I think these numbers are exciting. I've only got 4 months of data. I want to really see how it's going. This is in terms of our transport numbers. As you can see, we just started in We started the last week of August, so I put September in here. We did about 47 a day. We're up to about 60 transports a day, or we're averaging with those units, which is really helping us out. I'm trying to get a real-time dashboard with that to be able to have some better shots. They have a really good dashboard they use for the navigation. The transport's not quite there, but I'm trying to get it there in terms of sharing our data with them. Behavioral health diversion. Remember, this is where it permits EMS and 911 to divert the right care to the right patient at the right time, and that's a lot of times using resources that are outside of the normal EMS or police. This is the latest dashboard when we did this PowerPoint before we were stopped for technical problems. They're actively redoing this dashboard. They're making it a forward-facing one. We'll have more next time to be able to show you with that. Our medical directors, I just tried to briefly put a real quick slide in here in terms of the clinical metrics. Medical director review is one of our key performance metrics that we look at. It improves patient outcomes. It ensures that our members are given evidence-based care that aligns with our protocols. A lot of these things that they look at are things like stroke, STEMI, airway. STEMI stands for ST elevation MI. It's a type of heart attack that we're looking for, and cardiac arrest. One of the other things they're looking at very closely is our first pass. That we actually breathe for people. We pass a tube to breathe for patients that are unconscious and not breathing. We're looking really down in the weeds to be able to figure out what is our first pass success rates with that and how to improve those. This is the Utstein data. Dr. Lohner's behind me, so if there's any real deep questions on Utstein, I'll be more than happy to turn it over to him with that. The real thing that I really want to point out year over year with the key to this whole thing is bystander CPR. We need somebody to bridge the gap from the time until we can get there and bring, early defibrillation, early advanced care. That bystander CPR is a real important part of that. We're up in this particular time frame in FY25 to 25.8, but I want to take a second to look back. In 22, we were at 19.4. We went in 23 to 24.7, and then we're up to 25 and 24. It's a work in progress. We have to bring a lot of things to the table to try to improve that. Some of that is a dispatcher CPR initiative we've been working closely with. It's also the rapid access to AEDs and things like Pulse Point. This is the first quarter of 26. I wish it would look like this all the time. We're at least up to 30% here in bystander CPR. But we have a ways to go. When you put us against other jurisdictions like PG or Howard, PG County in the same time frame, their bystander CPR rates were at 43%, and Howard was up at 60. Chase car. I know we've been talking a lot about this pilot program we've been doing with the Chase car. We've had a lot of success. I'm happy to report we took that one unit to 24 hours a day, 24/7 on January 28th. The numbers here were 3,300 responses. The thing that I think is really important to point out, this is a car that staff with paramedics that upgrade the right type of call. 90% of the time, they're being upgraded, they're being dispatched to the right type of call. As of early this week, that number of transports is actually up at 4,778. Our community health program, population health initiative, there's a lot of important numbers we can go into the weeds on later with questions. I think some of the important things to point out, patient contacts in FY25 and Q1, we were actually at 9,600 patient contacts, which includes patients, bystanders, and family. Buprenorphine, we were absolutely able to induce 3 people, and paramedics trained in buprenorphine induction and training. We actually, when we first did this, we were only at 7. I'm happy to report that number is actually wrong. As of yesterday, it was at 59, which is roughly 50% of our available paramedics to be able to do that. Leave behind kits distributed. In this time frame, we've left over 8,800 kits, which is 7,000 doses of Narcan. And you'll say, why is that important? If you look at 24 versus 25, every council district in the entire city is down with overdoses, which is great. Some of these are significant. You also, if you look into the first quarter of 26, they're down. Why? That leave behind initiative. It doesn't mean the overdoses aren't happening. It means people are doing better. We're not going to those calls. They're treating each other. But that's the end of my slides. And I promise you I wouldn't kill you about that PowerPoint. And we're available for any questions you may have.
Thank you both. I'm going to say this and I don't see any other agencies in the room, so maybe I won't get in trouble until this video comes out. But I think you guys are the best agency in the city. You just do phenomenal work. You guys are incredibly responsive. You are always adapting. You're always improving. You're data informed, and everyone should run like you guys. And Chief, if I had a hat on, I'd take it off to you because it wasn't always that way. And I think the team that you have behind you has been doing a phenomenal job, just continuing to learn and continuing to improve. And I'm really proud of you guys. You continue to kill it. And every time you come here, you're incredibly prepared. And I just really proud of the work you guys are doing.
Thank you for that, Mr. Chair. And I think most, if not all, my command staff is in here. That it's beside me, it's behind me. I mean, I have HR, I have a lot of different reps in here. And I just, I'm blessed to have the people around me that I have. But thank you.
As a leader in my own regard, it's always a team. It's always a team. You get good people and you empower them. So I appreciate all you guys, all the great work you're doing. And every time you come in and I see how much we've improved, and even where we do have shortfalls, we quickly try to learn from them. And I think that speaks volumes for the leadership in each of your individual capacities. And I just want to give you your flowers because you absolutely deserve them. And, I've said this a number of times. The council president said it a number of times. I haven't heard the mayor say it, but I know he would say it behind, if ever asked. But I think you guys really are top notch, if I dare say, the best fire department in the country, just the way you guys are always adapting. So really proud of the work you're doing. I want you guys to hear that directly from my mouth. I have a lot of questions, a lot of thoughts. I want to give everyone an opportunity. Before we jump into questions, I want to acknowledge two members, one a member of the committee, Councilman Yitchi Schleifer of the 5th District, who's joined us, and Councilwoman Odette Ramos of the 14th District, who has also joined us. I want to jump to, I have a lot of questions, but because it was one of the last things you touched on, and it certainly is one of my favorite topics, buprenorphine. So Chief, you said that we have administered buprenorphine to 3 people. I'm very curious about what came of those inductions.
For that, I'm going to defer to Chief Cullen because he's hands-on with that. Chief Cullen.
Sure. Deputy Chief Timothy Cullen, Deputy Chief EMS. The feedback that we got from all 3 patients is that it did subside their symptoms. We were able to transport 2 of them to the hospital, 1 of them into treatment, and that 3rd one that we sent directly to treatment is still in treatment.
That's great. That's really good to hear. That's really good to hear. And I'm curious, we only got 3. Is there anything that we're finding that's preventing us from doing it more often? Is it, you mentioned we have 59 paramedics that have been trained, which is roughly 50% of all of our paramedics. Is it that we're still not quite getting to the calls, or is it just that we don't have necessarily the opportunities as often as we have the overdoses? What are we finding there?
There's a couple things going on with the change. With us rolling this out to the general public, there's 2 methods of giving that buprenorphine. One's like a film. Remember the old breath mint you put under your tongue? We're converting over to a blister pack setup because I have to distribute it and put it on the units. So that's part of it. The other part is to roll the training out and then the money for training. Remember, I'm taking people off the street when we're doing it. I think it's real important, though, to point out with buprenorphine around the area because I have the latest numbers. Baltimore County has been doing this since 2023, and they've only done 7. DC had done 12 and they came in line. I'm just trying to give you the real. Frederick came in 2023 and has done 7, and then we've done 3. We really got online. It was earlier, I guess in the fall with that. So the numbers are there. I think we're going to see them there. I think as we put the training out, that it's another tool in our toolbox to be able to help with that. I think one of the more interesting things, not only that, is that the community health, population health team, and Chief Cullen has the data, they've been able to actively get quite a few people into treatment and to at least try to get them in that direction.
That's great.
Remember, part of that program is to be able to build relationships, and then when people are ready, they're able to transition them, whether it's with buprenorphine or to be able to get them in those things. We've had a lot of success with that. A lot of people have been riding along. You yourself have been riding along with the team.
Yeah.
I think the next iteration or evolution of that is where we get more resources available in the back end. Once we get those people, we get them into treatment, we want to actively be able to do it. There's a lot of things coming down the road where we'll be able to track it with, like, they're using a platform called Goldie they're talking about using. There's different things like that. I think that's the next iteration. Is it going to happen in a minute? No, we got a little ways to go, but I think we're taking the steps to go in the right direction with that.
No, it's really good to hear. And I've probably been annoying about this issue for the past 2 years that we've been talking about it. And I'm glad to see that we're rolling it out. I'm glad to see that we're making it happen. You said that we started this, when did we start this? You said in the fall?
Yeah, there was a change. When we initially did it, it had to be a mobile integrated healthcare program. MIMS modified that in July, and by the time we got all that transition through and trained the people, that's where that transition came from. MIMS initially, who we take our rules from, basically it had to be a mobile integrated, like a pop health type environment. That's where we did the initial 7 trainings. Once they changed that, then we had to roll that out. Where are we gonna roll that out first? That's gonna be our highest trained people, our EMS officers, our specialty chase units and things like that, and that's what we're working through now. And then there's several grants out there. I'm actually looking at some now to be able to reimburse us for that training time. You know, not only to do it during the day, but be able to bring people in and get reimbursed for that. So working on that as well.
There was a bill passed last year that that I worked with a delegate to introduce that has money. Have you guys applied for that?
That's the one.
Okay.
There's an FY27 is due in March to be able to do that, and that's what we're trying to work towards to try to offset, because it's that or we're going to get killed with the overtime at the end of the day. So I'm trying to offset some of those costs as well.
And to that end, as far as the training, what are the challenges you're seeing on that end operationally? Are we seeing, because we don't have enough paramedics, we know that there's always a shortage there. Are we seeing any challenges operationally that we have to account for in training folks to administer buprenorphine?
Yeah, so the initial challenges that we have were, it was a very specialized field, so the training was about 4-6 hours. So to take it from our MIH component to do it to an operational paramedic, we had to kind of rewrite the training, condense it into 2 hours. Some of the challenges we face, it is a controlled substance. We have to be able to secure it, track it, inventory it, and things like that. Those were probably the biggest challenges. Once we got past that, and again, I only have a team of about 7 exceptional paramedics. Once they squished that training down with the help of Dr. Launer, we were able to roll those 59 paramedics through probably within about a month and a half to 2 months.
That's great.
So we went around the challenges.
Okay. Any further challenges that we might expect as we continue to train paramedics that we should be aware of?
For us, no. The challenge we have operationally and clinically really is just a lot of patients won't consent to it. A lot of patients aren't in a condition to consent to it. And a lot of patients with polysubstance abuse, or they're required, we have to treat other critical illness before we can administer bupe because of the type of treatment that it is. Those are the biggest challenges, and probably the reason why our numbers are only low. Most of our patients either don't qualify for it or don't want it.
It's good. I think
Dr. Launer might have a little medical.
Dr. Launer.
Thank you. I have a couple of feelings on this subject. Ben Launer, Medical Director, Baltimore City Fire Department. I think it's important to state that we do not work in a vacuum here, and I think we understand and appreciate the challenges. And part of our job, as I think as you so well said, is to integrate them into a protocol that lowers the barriers. So one of the things that we've seen is right now this is still a special protocol. And as we are bound by, let's say, Maryland Institute for Emergency Medical Services Systems, one of the things we are working on is right now this has to live within the protocol. So if we want a protocol, let's say like Hennepin, which is often discussed, it needs to be given to all paramedics, which we have successfully done, and then it has to live outside what's called a mobile integrated health module, so documentation. So I think we all understand the challenges. I think it's also fair to say it's not an optimal result right now, but this fire department, in conjunction with Medical Direction Chief Matz and Deputy Chief Cullen, I think we're working to resolve those so that in a future iteration of that, we've removed all of the operational barriers and we've condensed the training even further. I'm optimistic that will happen because we carry these discussions forward in the protocol review committee and all of the challenges. So looking forward to, I think, a lower barrier state where it's actually integrated in a lot of the follow-up. So it's very encouraging, but certainly slow moving because of how it's set up. So it is positive, and certainly appreciate the opportunity to acknowledge that progress.
Yeah, Dr. Lawner, I would push back on one thing. I would say it is a success thus far, if only because there's at least one person that has accepted it and is in treatment. And I don't expect that we're going to immediately turn around and every person that overdoses is immediately going to have this medication available to them. But I do think for every life that we're able to save, and even more for every life that we're able to put on the right track, it speaks volumes for the innovation that we're doing here. So I just appreciate you guys figuring it out. I know it took a while to get the protocols changed. I know it took a while to figure out operationally what needed to happen, and even more how to secure a controlled substance, on our medics. But appreciate you guys, figuring out all the tough stuff to make it happen. So my second question is going to be around the inspections. So I had an opportunity to go out with you, Chief. 3 weeks ago. I'm losing track of time. I'm getting old. To knock doors and talk with folks about their fire plan. And I'm looking at these numbers, and they're great. We're hitting a lot of residencies. We're putting a lot of making sure people have plans and otherwise. I'm curious. We've been doing this for a few years now. How soon until we have touched every door in Baltimore?
I don't have a direct answer for that. What I will say is kind of in line with that. We're starting to look now at our home visit data where we got no answer at the door. And I've spoken to this group before. Last year we identified an age group that was 53 and older in our fire fatality numbers, right? And the average age was 53. This year it went to 61. Mm-hmm. So although the number of fire fatalities came down, the age group stayed high. In that 53 number, from 2 years ago, there were 3 children involved. So those younger ages, right, brought that number down. So if you pull that out, we're still up in the 60 degrees, just to kind of surmise that. So what we started doing, we wanted to look at it a different way, and we're about to roll this plan out. We've taken 3 years worth of fall data, where the call type for EMS was a patient that fell. And we've tried to narrow that down in an age group of 60 to 100 years. We have those addresses. We're trying to take those addresses and go back and look at the home visit data to see where there was no answer at the door, right? Although you might knock on a door, I consider a no answer to be, it's a no visit. So we're trying to see where in that particular age group we've been. Our EMS has provided service because of a fall. That's the easiest way to classify something, right? It's the most common call in that age group. And then go back and look at where we've been and we've not been able. I don't know that we'll ever get an answer at every door. I think we could reasonably say that we could knock on every door in the city, but that's not the benchmark I'm using.
Right.
I need that door to open. And that's why, in the times that you've all been out with us, we're real adamant. We take the time, right? It's not just hey, do you have smoke alarms, do they work, and we move on. We really try to take some time and go granular. That's, I guess, the best answer I can give you is we recognize it, but I'm not just looking at contact with the front door. I'm looking at contact with someone behind the door, and we're trying to figure out ways to really, really get FaceTime with people, and that's just one way we're trying right now.
That makes a lot of sense. And as you were explaining that, it makes me think a little bit too of the temporary nature of the smoke alarm, because you put it in and the batteries die after maybe 2 years.
I think we're using 10-year batteries.
10-year batteries.
10 years,
Where do you get those? So, yeah, but, you know, to that effect, we know then we should probably go back to these residencies in 9 years or so, or 10 years, to make sure that those batteries are still working. Just a thought as well.
Yeah, and I can remember in years past, well before I was in this position, but we knew as we phased in 10-year batteries through the city, we knew at some point in time the need for smoke detector replacement because the faulty batteries would come down. So, you know, we knew we were going to see kind of those peaks and valleys. I think right now we're in a bit of a peak. If you look at the numbers that we show, there were a lot of visits, there were a lot of inspections, but we're putting in a lot of smoke alarms too. So there's good consistency there, but I'm kind of wondering if that number isn't going to trend up a little bit.
Got it. Thank you. Questions? Councilman Schleifer.
Thank you. Chief, which hospital's in last place?
It is not what you think. It's Harbor Hospital.
Harbor Hospital. And what are what's the wait times there?
Last week, they were at 58 minutes for 90% of the time, which is what I look for, to be able to get people in and out of the door. It's been going up and down. I think with the flu, it's ticking up a little bit. For a while, it was living right about 47 minutes, 45. The goal, and just to talk about the offload, the goal through MIMS is to have a response standard that the hospital get us in and out within 30 minutes, and that's where they're trying to get to. There's actually discussion of making that as a performance metric with the global budget, the way they're paid.
Yeah, it's interesting because when you look up some of the hospital self-reported metrics, they'll make it seem that, you know, they see people who come in the door within a few minutes, and they put that on their reports. When we clearly know that's not the reality, other than maybe a security guard out front saying hello to them as they walk in. But is there anything we could be doing to penalize these hospitals that are costing us all this time and money by not having a better intake process?
A lot of the hospitals, I'm going to let Dr. Lorna speak after I do because he knows from the hospital side too, but they've made a lot of strides with regard to us getting off. The thing that's surprising, which you wouldn't realize, and a lot of EMS only accounts for like 10 to 15% of the call volume in AED. A lot of the rest is walk-in traffic. With us, it hurts us because of the trickle down. You know, there's only 30 units available when we're getting held up, and that's one of the problems. It's one of the reasons I bring in the surge to help offset some of that, especially during the peak of the day. A lot of hospitals have gone to bringing in a nurse that specializes in just that offload process. Some haven't. Some hospitals are better than others. Initially, I thought it was the busier hospitals were worse. Some of the busiest hospitals are actually the best at offloading patients. So it's a work in progress. Dr. Lohner, I'm sure you have a lot to add on that topic.
Thank you. I'd address a couple of things. My last shift at university, we had 70 people in the emergency department and 40 people that were admitted in an active bed space of 28. So the global budget is pretty dismal for emergency departments. I'd like to respond to your question by saying a couple things, which is really important. So number one, you're correct. The metric of physician to seeing the patient, a door-to-doc time, does not reflect offload. So when the ambulances are stacked at university, I will go and see them. They're not offloaded, but I meet the door-to-doctor metric according to Medicare and Medicaid, which is frustrating. Now, the goal of that is not for me to lie to the public and say, for example, I'm seeing people in offloading, but it's to at least start the downstream care in the absence of bed. But I do agree that there is a disconnect. Number two, the regulatory pathways currently do not exist. So MIMS does not regulate the enforcement in hospitals. They regulate EMS. We participate in the regional advisory councils, and as Chief Matz had mentioned, there was discussion about penalties, but that was not passed. So we, of course, strongly encourage offload. I think any regulation about finding hospitals or some other ways of disincentivizing them has to come from either the city or another channel, because right now there's no way for the fire department to leverage a fee. It is very challenging. The third thing I would say is, like everyone else, is I want to echo some of the positivity. So our 30-60-90 offload policy, which incentivizes for offload in addition to our direct to triage policies, have really minimized this since the era of COVID. So the fire department is actively engaged. It is a problem that extends well beyond the jurisdiction. I certainly appreciate the opportunity to talk about it. Not a lot of easy solutions that are kind of on the front line.
So, I mean, is that something that the city council has the authority over, or that's, because MEMS is a state entity, so does that have to be state legislation, or, to your knowledge, is that something that the city could pass as a city ordinance?
This is a great discussion, and I certainly don't want to be responsible for finding all of my colleagues. But the difference between protocols, so if we look at buprenorphine as a model, we, as the city, would not have the authority to countermand a regulation. My understanding is that there's no regulation that talks about whether or not the fine can exist. So whether or not it would be reimbursable or whether we could collect it is a very different issue as to whether we would have the authority to fine them. I am aware of several cities and several jurisdictions which propose fines for standby. So there are lots of things that are possible. I am not aware, to answer your question, of any regulation that would preclude us from fining area hospitals.
What's a good one, like another jurisdiction that?
I can certainly get back to you, but I am aware of them where they do, let's say, standby costs. So for every hour they would bill the hospital. Whether or not, again, those are collected is an entirely different matter. But I can certainly collect those policies and forward it up the chain of command.
I appreciate, yeah, if we can forward that over, because, I mean, we do have, if there is citation enforcement, then the city does have the ability to not issue permits and other authorizations that these entities would need until those previous fines have been paid. And because, like, the way I see it, and I hear this, as a morale issue from some of the EMTs on the ground, is that, when they're sitting there for long wait times, when you're in the hospital, and I've seen it firsthand multiple times, they're more incentivized to deal with a walk-in than they are with somebody who's standing there with an EMT next to them, because you have less of a liability. If you have somebody an EMT who's sitting there basically giving one-on-one attention, somebody walks in, you don't really know the severity of what's going on, they're going to address that first. So unless there's some type of equitable, priority, then what they're basically just pushing that on to us, but that's having a big effect in the city, because if we can't be out there on the street and we can't get the EMTs, EMS back out on the street, well, then we have more people losing their lives on the streets to natural causes as well as unnatural causes, simply because our response time is too long because they're holding us in these hospitals.
That is absolutely correct, and I appreciate that sentiment. I will say that the fire department does report up through the existing regulatory agency, which is the Office of Healthcare Quality. So if it extends beyond a duration, we have talked with City Legal and MIMS, and we do leverage that. And what that triggers is a EMTALA audit, which is quite unpleasant, because the reality is, according to federal law, EMS makes the request for screening upon arrival. So whether there's this false reassurance or not, they're still obligated to take care of our patients. But the fire department does report, track, and follow through on those egregious offload times with the regulatory authorities.
Gotcha, thank you. And my second question, Chief, going to the pods that you mentioned in the beginning, what does a pod or something like that cost?
Chief Stewart, do you have or Chief, I'd have to ask logistics. They're working through that.
All right, so basically the pod is, like Chief Wallace mentioned, is a sea container, and we're going to have different disciplines set up. One will be a mass casualty pod set up. One will be a special rescue operations collapse, one for hazmat. So basically the surrounding jurisdictions, they have them already. We saw it and we figured that we could benefit by having our own. Even though we do train and partner with them, us having our own is definitely more beneficial. And again, this is like Chief Wallace said, it takes away from bringing multiple vehicles to the scene. And we can, prime example, Key Bridge collapse. We can have our special rescue operations pod set up. So that way we drop that and the dive team can set up their command post inside this pod, as well as bringing any other equipment to the scene with this vehicle. So we'll have pictures.
What's the cost, the ballpark cost of the pod?
It's likely going to depend on which discipline that we equip it with. The sea containers themselves range somewhere between $10,000, $15,000, just the container. And then it's a matter of what discipline we would put in there, the amount of equipment. In comparison, significantly less than a heavy rescue unit, significantly less.
So whether or not it has wheels on it as a command center versus not having wheels is what kind of cost differential?
So say for instance, vehicles are running $500,000 now. So if we had to provide a vehicle for each discipline, you're looking at $3, $4, $5 million, depending on how many vehicles versus a couple $100,000, $100,000 per pod. So you can have a vehicle and 10 pods for $2 million, maybe.
Okay, so what's the ballpark figure of a pod versus a vehicle?
Like Chief Wallace said, it would depend on the setup of the pod itself versus the vehicle itself. So we can get that number for you and have a comparison
Yeah.
ready for the next
Yeah, I
presentation.
mean, yeah, it would be helpful to understand that. Obviously, I support it if this is something that you guys need. A pod takes up pretty much the same space as a vehicle. It's whether or not the pod has wheels and a steering wheel on it is a few more feet, and obviously is more convenient than, a truck coming and dropping down like one of those storage units or something like that. And so if there's a significant cost differential, then that obviously makes sense. If you have in one of your yards, 10 different pods for 10 different uses, and the truck goes and picks up the one you need for that scene and drops it, sure, that makes perfect sense. But I think I would just need to understand like what the cost differential is. If you tell me that it's 10% of the cost of a vehicle, then certainly that makes sense. But if you're telling me that, it's $50,000 difference between a vehicle with that same discipline versus just a metal shell with it, obviously I think that it would make more sense to have the vehicle. So if Chief Stewart, if you can please get that information, that'd be great.
Yes,
Do
sir.
you have a timeline? How much time do you
I
need?
could probably have it in about a week.
Okay, thank you.
Okay. Please, Jen.
Yeah, that'll probably take a little bit longer than a week. We have to submit everything and have it reviewed, ensure the data is okay. So probably 2 weeks.
2 weeks, good?
Yeah, fine by me. I just
All right.
want to understand it better.
Thank you.
2 weeks, thank you. Councilman, you good?
Yeah, thank you.
Thank you, Councilwoman Ramos.
Thank you, Mr. Chair. Also want to thank all of you for your amazing work. I really appreciate it. I have a couple data requests and some questions, and I appreciate this time, Mr. Chair. I am increasingly worried about, we've had several reports in my office from across the city of residents not having heat and using space heaters, and it is causing fires. And I'm wondering if we can get information about the number of, if you have a cause for the fires, because we haven't actually talked a lot in these hearings about causes, other than that there are fires. And so I'm particularly interested in the data related to the occupied and how many were from space heaters or something related to that. Can we get that from last year compared to this year? Actually, the last 3 years of information?
Fires
I
and
know
op-
not always, you don't always have determinations at fires, so I get that. But if there are those determinations, I'd be interested in that.
Fires in occupied structures that result.
Occupied.
Occupied,
Mm-hmm.
okay.
Yeah. I have a whole lot of stuff from vacants, but I think I've already sent that over to you.
And what is an appropriate timeline between the two?
I would say in the next couple of weeks is fine. I'm not in a huge, it would be good to have, because then it's helpful for yelling at certain parties that have high heat pits.
Is a month okay, Councilwoman?
Yeah, that's totally fine,
Yeah.
yeah. But also, it goes into our work around particularly older adults, and if we're not getting, I want to compare that data also to our home repair work, if we're not getting to people in a timely manner, that kind of thing. So I think it'll be super helpful. The other is, and this goes in the same kind of vein. Obviously, we have a lot of water pipe ruptures, and residents call 911, and I think those calls are diverted to the fire department sometimes to turn off the water. Can we understand that a little bit? And I would love to get the numbers on those in the last 3 years as well. Again, obviously, we all put out, and I follow your guidance to put out word about, how to deal with burst pipes, but I have a constituent who does not have heat, and therefore she has frozen pipes. And luckily, they haven't burst, and we were able to get her help, but if we hadn't, that could either be a fire or burst pipes. So the same time frame for that as well, if you're getting, mostly the 911 calls on burst pipes.
3 years?
The last 3 years, yeah.
Okay.
Yeah. That would be super helpful. And the other reason for.
Is it a month okay for that? as well?
Yep, totally fine, same time frame. Yep. The other reason for this, just to be transparent, is that BGE is not giving me data on who does not have power and who does not have heat. And that is necessary for us for the reasons that I told you about, but also on the vacant property side, which I'll deal with later. So I really appreciate getting that information for occupied. Your information, I just asked you for those two. I want to better also understand, and maybe I have asked this in past hearings and I just got too much going on and I forgot. The classification you have for occupied, fires in, unoccupied properties, that classification, is that just that nobody was there, the owner was not there at the time? And so it could be that they're gonna come back and they'll see what's happening, or is it that there's like nobody living there? Or do you distinguish between the two? Hi.
Yes, ma'am. Good afternoon, John Ide, Assistant Chief of Operations. The unoccupieds are at this time that the fire department arrives, that it's unoccupied.
Okay.
Yeah.
Right, so you basically wouldn't know whether there's gonna be somebody coming back later unless, I think our crisis services might have a little bit more idea than I would on that, but, okay.
Yeah.
Yeah, I appreciate that. I just wanted to clarify that as well. And then I haven't done a Codex analysis in a while, so if I could have the last quarter of the, so that would be fourth quarter of the calendar year, Codex removal data, that would be helpful. I want to kind of see where we are on that, given the information on the vacant side.
Can you clarify, are you saying Codex removal data as in
Yep,
it's been removed from
so
the Codex
during their
designation?
inspections, they remove Codex if they're seeing that a house is rehabbed, right? And we've been looking at that data to see whether or not those houses are actually using permits. And that's the reason to see that, is to see where we are on progress of people actually utilizing permits. And I don't think it's much better, but I do want to be able to see that information. And that's been helpful, I think, for you all to then get that back and see like what is happening. Because if folks are rehabbing properties without permits, we've got a problem in terms of health and safety.
Yeah, that's, just to respond to that last part, that's driven change within our department as well, operationally.
Yeah.
We're now using a banner in the CAD system to advise our people that it used to be or a former Codex, because again, we have no way of really verifying the validity of the work that was done. And in some cases, the work can actually make the structure more dangerous.
That's right. Yep.
And that goes back to that critical thinking piece I was talking about when
Yeah.
I was presenting. we have to be cognizant of the fact that, it was a Codex. We know if there's people in there, we've got to do everything we can to get them out of there. But we have to be very cognizant of the fact that at some point, we deemed that building
That's right.
in a condition that, could have been imminent collapse or whatever, and now it's not. So we've really drilled down. Chief Ide's done a lot of work with that, with his shift commanders. They've got it in CAD, we've got the banner, so they do see it flash when they're on their way to a fire.
That's good to know, and I'm glad you're doing that. Because I, again, get concerned because even if, when you look at the Acela data, you have to really dig down to see if it's got the proper permits, because a lot of times if they did have permits, they're not the proper ones anyway. So it does take a while to do that analysis because it does get, but I want to see, I haven't done an analysis in a while, so I want to see where we are. And I did last year's last quarter, so I think it would be a
Quick
good
question.
comparison. Yeah.
Do we know how many Codex properties we have right now? I know the numbers we put up were based on June 30th, 2025, and then we had the additions. But what's the total number of Codex properties we have? Do we know that?
I'm being told somewhere, in that 5,600.
5,600, okay.
Again, that's real dynamic, and I think what's really helped us be successful at keeping an eye on this has been our company officers and the crews in the field. They go by, they do a reinspection on what they have known to be a Codex, and there's people on the front porch, right? There are kids playing in the front yard.
Yeah.
There are people looking at them, out through the window, and that's the data that we're looking for. We're looking for that quote unquote return from Codex. We automatically get that in CAD, but then we need to validate that as well, right? And that's it's so critical to what we're doing.
And I'll ask this question to my colleague because she probably knows it like the back of her hand. How many total VBNs do we have across the city?
As of this morning, just a little over 12,000.
Okay.
So I think we had discussed.
We're looking at about half of our VBNs are Codex.
Right, so I think what the difference is between the Codex and the VBNs are that the Codex are fire department inspected, and the VBNs are some are very historic VBNs, right? So there's some melding that you could have a VBN with a Codex, but you can also have a VBN without a Codex that might be in a better shape. And also, I don't think the entire
Can I
city's-
clarify?
Yeah.
Every Codex has a VBN?
Not necessarily.
Why not?
Because we do have an issue with DHCD not always giving VBNs where they should be.
That doesn't make sense.
Yep,
Can we fix that?
we're working on it. Yeah.
Yeah, that seems obvious.
But also that my understanding on the Codex side is that the fire department is, have you inspected the whole city yet? Yeah,
If we haven't, we've
inspected the entire city,
we've just,
yeah,
I don't know how we couldn't have.
right.
There's just so much out there. I mean,
Right.
from the SSUs that are grant funded with
Yeah.
that initiative to the companies, to the weekends that they're out, it's been intensive for the past few years.
Yeah, so I think, I mean, it's very rare that a Codex would not have a VBN on it, super rare. It just might be something that happened at DHCD.
We should necessitate that by the very nature. If the fire department thinks that this
Right.
building is at risk of falling down.
It should get I
should get a
know,
VBN.
I know,
Yeah.
yeah, absolutely. We can bring that up on our hearing with DHCD later this afternoon. And I would imagine that these new codexes are based on, because of a fire in some cases, right? Because we put VBNs immediately on, well, I got one that we didn't, but I mean, right, immediately.
Another
on
question.
that. So, so that's what that is, right? I mean, I guess the curious thing is what these new codexes are based on. Fire, you think, or what are they based on?
Yes, ma'am. I believe we do actively, probably every time we have a structure fire that's significant, we add them
Yeah.
in there immediately.
Yeah.
So there's probably some lag time with that information getting to where being known that that's also a Kodak. So I think with our SSUs, we've really been concentrating on the TES enforcement zones recently. We've been able to do a lot more inspections in those areas for about 8 hours versus when the fire companies are out there, usually out around 2 hours because they have other activities. So I think we'll see that slow influx of a little bit more, but then we also return them to normal use. So I don't know for each specific one, but I know that each structure fire that we have, we immediately deem it a Kodak if it's structurally unsound after the fact.
Yeah, okay, that does match with your other data, so that's why I figured it was the case. Okay, yeah, thanks a lot, and I appreciate that, that data sharing with me. I appreciate it. Thank you.
Thank you, Councilwoman. You give me some homework here. I have a question about, a quick question about the injuries. So we saw a 49% decline in injuries, and I noted most of those were around vacants. Can you remind me what change we made in how we manage entry into vacants and working around vacants that maybe contributed to that?
So it's a blend, really, of tactical changes as well as the enhancement of critical thinking. So we want these 360-degree views of a building before we make an aggressive entry. Of course, the codexes are no-go. The redundancy that comes behind either the initial incident commander arriving or an officer, company officer in the rear giving a report, the built-in redundancy is a safety officer that arrives as well. The safety officer is going to make that same trek around the building, and they're going to look for hazards. Hazards on firegrounds are not limited to just the building itself. BG&E lines coming in, holes in the yard. Construction sites are well known for all kinds of problems. So we're not just looking at the structure itself, we're looking at all the environmental conditions that go into play. And then finally, I would just say, just the way that we're fighting fire now. I believe we're a different fire department than we were a couple of years ago in the way we fight fire. You don't see people running all over the incident scene. You see our people, they're very deliberate. They put a lot of thought into what they're doing. You get a rescue incident where people are trapped inside. Obviously, they're going to pick up the pace and they're really going to move quick, and they're extraordinarily good at it. But it's the way that we see the incident and the way we see ourselves, I think, is probably the best way to surmise that.
Awesome. Thank you. And then lastly, I had a question about the Fire Academy and the numbers of folks coming in. We saw that nearly double from Q1 2025 to Q1 2026. I was curious how many vacancies we're looking at in the department and how this increase helps us there.
So the entry-level EMT firefighter, the recruitment's done right off the street. We're somewhere around 20, and I'm gonna kind of look at Dr. Hart as I answer this. Somewhere around 20 to 25.
20 to 25
vacancies, right? So, but we're also in the process of reclassifying some positions. So the reason we're doing that is we don't just hire firefighter anymore. We don't hire the job classification firefighter paramedic. We hire EMT firefighters or lateral entry trained clinicians, EMTs or paramedics. So there's somewhere right around that 20 to 25. There may be a 22. She's saying. Okay. There may be a handful of quote unquote firefighter positions that we're reclassing. We're projecting, we have an EMS class in now. We're trying to bring another EMS class in next month, and we're projecting the EMT firefighter class to start, I believe, in May, and sometime in May. So, which is a good thing because any attrition that occurs between now and then, we can get them in that class. But I believe we're in a very favorable position, at least for those entry-level positions. I'll let Chief Matt speak to EMS side. That's the fire side, though. The numbers are low.
So we've made a lot of inroads in terms of the assistance of the team and HR with getting the recruitment and getting a lot of EMS folks in. The last numbers I looked at, I think I have right around somewhere between 44 and 50 But you got to understand, when we started 24, I look back, I was at a 35% vacancy rate. I'm down to like 12 or 13. So we're going the right direction. We made a lot of inroads with that. I'm always going to have people coming and going. We're trying to just kind of stamp it down and bring in a lot of people. Paramedics are still a challenge for everybody. I get on state calls and it's a joke about who's stealing who from who, because that happens all over the place. We're also working on some different initiatives where we have our people learning paramedic through BCCC. We're trying to, grow some other paramedics from within. We're also looking at a new program called EMS Corps to bring in some additional EMTs. So we're trying all different ways to bring in new people. The list I just got from HR that I'm looking through, there's like 70 EMTs, but the problem is people go on there and they don't upload their cert. I'm looking for people that are already licensed. A lot of people are just saying, oh, I can just go and get it. So we have to really filter through the list. I think the latest list we got for paramedic and ALS type people, I think it was right about 12 people. Was that about right? About 12 paramedics. They're hard to get. So we're trying to move as fast as we can. We've actually refined the process. Instead of it taking a real long time, when people come in and take the physical agility piece, we're actually doing interviews that same day. At the end of that day, we're actually offering appointments to go to PSI and go through the medical part. So we're trying to accelerate everything through so people don't lose interest or go to another jurisdiction too.
Yeah. The paramedics issue is tough. I remember in a previous hearing, we talked about efforts to train EMTs up to paramedics and to potentially look at incentives or various other ways to get more paramedics through the door. Have we any progress on any of that we can speak for?
We've had significant, what I'll do is I'd like to defer to my operations chief and have her come up. She knows we've actually been able to, I think we have 10 people in the program now, and I think we've successfully brought in, and I'll let her speak. I think we've been able to get another 7 to 10 people through the program.
Yeah. And it was like a partnership with the community colleges?
With BCCC is.
Yeah.
Good afternoon. I'm Deputy Chief Vanessa Sawyer. I'm EMS Operations. So the program he's speaking to is that we are allowing our members, I guess if you say, to go take classes. And we've had, I think it was 18, a combination of CRTs advancing to paramedic, and we have EMTs that are advancing to paramedic. So we're partnering with the BCCC. All of them actually go to BCCC. So right now we have 18 that actually completed the entire program and are now functioning in the city as paramedics.
Awesome. That's really good. And then, in thinking about recruiting the pipeline, it seems like with the BCCC program, we're priming the pump, preparing folks in advance. I'm curious, are we preparing for the tail end for folks who are eligible for retirement? I'm curious how many folks will be eligible for retirement in the next year, just so we can kind of see into the future and know that we need to meet a recruiting goal in order to close any potential gaps, or potentially offer incentives to keep on someone beyond their retirement age.
We'd have to give you, we could give you a breakdown. I guess it would, we never really know when they're going to leave. I guess if we, maybe a breakdown of time in service, right? 20, 25, 30 years would probably be the best way to at least show. That's what we look at. We look at who's coming up on that retirement, service retirement time. And that's how we kind of gauge, where we're going to be. I think that's probably the best way we could give it to you.
Okay, yeah, that'd be helpful. I think less for me, more for you all, and just trying to see around corners with our staffing, knowing that we have such a shortage of paramedics and it's always hard to get more. And even for EMTs, if we see people cycle out more quickly, becoming firefighters or otherwise, whatever we can do to prepare in advance for any attrition that we might expect in the force. So I'm just trying to see around corners, that's all. Those are all the questions I have. Once again, you guys are amazing, so every time. Any other questions, folks? Seeing none. Thank you all. It's always a pleasure to have an opportunity to touch base, see the great work you guys are doing. It's amazing to get the opportunity to work with you. Happy New Year, and looking forward to a new year of new success. So with that, this hearing is in recess.